it's probably not the best place to start, especially if you want to eventually become an FQHC, because that particular neighborhood has to be already designated by the federal government that it is a medically underserved area. And if it isn't, you still can apply to make it and designate it one, but it actually is an involved process where you actually do a service area application where you essentially tell the federal government that this X census tracts and these zip codes and so forth justify your designation. But even then, that doesn't guarantee you getting the grant. You just designated just that neighborhood. So that's an important piece, especially if you're thinking about an FQHC, is to essentially look at your place or where you're at, and whether it's a MUA or a MUP. The services that you provide have to be comprehensive. So it can't necessarily just be one particular area. So core, primary, preventive mental health, preventive health, and I'll go into the required services later on, so I won't spend too much time there. Culturally and linguistically competent care. When first started, we had a lot of volunteers from undergrad volunteers that didn't necessarily speak the language of the community, and it obviously impacted the quality of care. And so a lot of times, like for example, we have now, alhamdulillah, 42 employees.
Extremes of where,
from the community.
In my internship here on my transplant rotation, sure I did 1 week there was 135 hours, and another week there was 130 hours.
And then
you can't do that stuff now, but
it's not so much just because you're providing care to an underserved population should justify subpar care. You actually, the federal government holds you to certain standards that are held, and now even more so because of health reform, that are held, that hospitals are, whether it be JCO or NCQA and so forth. So just every year, for example, has to submit to the federal government our healthcare plan, our business plan, and each have to be actually specifically delineated what our health outcomes are, what are the specific clinical priorities we want to achieve, whether they're both clinical as well as actually services that are necessary, for example, enabling services. Are there questions any so far? Or we'll just keep that towards the end? Yeah, all right, let's go ahead. All right, so the FQHC requirements. So you must demonstrate first via needs assessment why your application is worth sending to the federal government. And so you essentially have to do a full-blown needs assessment. You have to prove to the government, which is reviewed somewhere in Maryland, that on paper in a 200-page application, why your community needs another health center. And that tends to be very, very difficult. It's scored at a specific, they score highly in the application's need, collaboration, your ability to actually translate the need to the services that you provide. So these are just a list of services that you have to provide above and beyond just having a doctor see patients. And that includes enabling services, whether it's transportation, translation services, being able to actually do case care coordination. Oftentimes the uninsured, underserved populations, hospital admitting privileges, making sure you have a continuum of care. And then ultimately, you have to be able to provide services regardless of ability to pay. This is a very, very extremely important point, because a lot of our patients, prior to health reform, they were not poor enough, unfortunately, and according to the federal poverty designation, and we had to ask them to pay. But it's completely up to each health center how aggressive they're going to ask for collections. For example, kind of just, we say, here is what your charges are today, this is your sliding fee, and we kind of just, and surprisingly, a lot of our patients actually do make it a point to pay, but there's another extreme where other health centers in the country actually send their patients to collections and so forth. So it takes a whole diverse mix. Program requirements, so here's probably the most difficult barrier that experienced was the governance requirement. When the board found out that, when I was sharing with them one of the requirements, they're kind of just saying, okay, that makes sense, we want to be a better institution and so forth. Oh, you want, the majority of the board, which at the time were founders, to essentially be ineligible to serve on the board, because we had, the majority at the time were physicians, and the rule is 51% of your board cannot be physicians, right? And then the 49%, the majority of that 49% cannot receive more than 10% of their income from the healthcare industry. So it's not only just physicians, it could be a healthcare consultant, it could be a person who is business law, but he or she works in healthcare and so forth. So essentially, and this is what a lot of respect that I have for the founders, they gracefully stepped off, they had the big picture in mind, and they bit the bullet and said, you know what, let's make this board eligible. So it's essentially, that's probably the biggest barrier for FQHCs, because they truly, and they really mean business in terms of making sure that this particular requirement fits the operational mode of the clinic. So what are the benefits? Why go through all of this? There are a lot. You have access to federal grants up to a maximum of $600,000 a year, and they are somewhat renewable. You compete every 5 years, but essentially a $600,000 grant to offset your uncompensated care is a pretty good deal. You also get enhanced PPS rates. So most docs, the reason why Medicaid populations are poorly served by private physicians is because the Medicaid rate is poor. And in California, it hasn't changed since the 80s. But as an FQHC, you actually get an enhanced rate that's based on cost. And it's fairly technical, I won't get into that. But it's actually a very good thing for right now, because that will also change in health reform. Discount drug pricing, we all know pharmacy costs can be significant. The federal government will cover for FQHCs, your malpractice, the U.S. Attorney's Office would actually defend you if you have a malpractice case, so that's pretty significant. Access to vaccines. You become a site that you can attract physicians and pay for their student loans through the National Health Service Corps, and also the fact that FQHCs were written in as a core backbone of the Affordable Care Act. So in other words, the health reform was essentially built around the successful models of community health centers. So in terms of sustainability, that's a good position you want to be in. Now, specifically, the lookalikes are essentially very simple. A lookalike is you have to comply with all FQHC rules, but you don't get the grant. It is difficult to kind of do all that, but there are benefits to that anyways. You do get the enhanced rate. You have to make sure that you're still in those underserved populations and so forth. So as I close, there is significant, and some are already expended, monies from the Affordable Care Act, where essentially $11 billion over the 5 years. Some have been actually already expended, like $1.5 billion in the capital, to actually build new clinics. That pot is gone. Expansion 9.5, that 9.5 billion is still being debated in any of the debt ceiling discussions we've had recently. So some of that money's been extracted, but by and large, the money that around the health reform act actually built in the infrastructure of supporting new health centers. And so that is something to consider in terms of where the healthcare system is going and the investment. Opportunities to become an FQHC, from the perspective of a health center that we were a free clinic and we were a community clinic, you're best positioned to serve the newly uninsured. There are definitely growth opportunities. These whole concepts of the triple aim, based on cost, quality, and patient outcomes. Free clinics and community clinics have been doing that forever, especially care coordination, patient-centered medical homes. All these things are now kind of in the works that we've been working on for the past 2 decades. So there's definitely opportunities for FQHCs to actually leverage that experience. The challenges, of course, is that community health centers will no longer be the provider of last resort. In other words, we shouldn't visualize ourselves as one anymore. Yes, we still will be serving the uninsured, predominantly the undocumented, but we have to change our model of actually building up our capacity to do customer service, to retain patients, because there's going to be a lot of new players coming in to serve the Medicaid population, and so FQHCs have to be able to serve that population. There is uncertainty with how we will be paid, but that gets in a whole other, in the next 2 years, that's where the FQHCs are going to be fighting as to the best, how do you maintain how we were paid before, and how does that fit into the new models of payment and reform. And the only last point is the Supreme Court decision now made all Medicaid populations, or potentially delivery of services to Medicaid populations, very different in different regions. And so some FQHCs in some states, if you're in a state that chooses not to truly commit itself to health reform obligations, then a lot of those FQHCs are caught holding the bag of providing uncompensated care on their own without any state-supported programs. Sorry, I had to rush through all of that, inshallah, in respect for all of everybody's time. But inshallah, if there are questions and answers, or you wanted to wait till...
No, you have to
Yes, yes. So if there are... It's a lot to process, but if there are a lot of... Any questions or... Yes?
Are you guys thinking of in future, say, franchising in Muslim? Or another question I have is, do you have a list of resources available, like grant writers or other resources in case somebody is pursuing the course of FQHC? And also that, what's the initial cost of running, like before you get FQHC, like running FQHC lookalike, the initial cost and also like running cost for you?
Okay. The first question around the franchising, we get that a lot. It tends to be very difficult to actually franchise to get scale, if you will, as opposed to like maybe a hospital chains that actually can gain scale in terms of moving and having a system to actually open up clinics within different regulatory environments. As you know, or everybody knows, LA is very local in terms of different, from county to county, state to state could be very different. So I haven't seen too many FQHCs actually cross state lines. Some have actually crossed Orange County lines, but we haven't really considered that as a long-term right now. But that can be definitely in the future to at least move maybe in different counties. For resources, there are a lot of resources. The National Association of Community Health Centers has an extensive resource for FQHCs or people who want to open one. I often can ask people to look up in Google the title, "So You Want to Start a Health Center?" And it's a 600-page document. Don't get afraid of that. Just look at to get an idea. The table of contents can kind of give you an idea of like the frame of what it takes in terms of infrastructure, which kind of leads to your third question, which is what are potentially the costs? Well, you can become a FQHC lookalike, but there are certain infrastructure items that require a budget, like, for example, the level of management, the ability of, for example, you have to have a clinical lead, a CEO, you have to have a financial, so the overhead can be significant if, especially, you have to also ensure that you have billing and you actually get third-party payers. So our budget when we became an FQHC lookalike was $2 million at the time, actually 1.5 million at the time. So it was still relatively, we only had one doctor at the time. So now with next year we'll be at five physicians. Inshallah, and so it varies in terms of budget.